podcast. Today, I will be speaking to Dr. Martin Pedernera about the predictability of aligner treatment. Martin is an experienced orthodontist with aligners, and I'm sure you'll be very interested by what he has to share. Enjoy. Welcome everyone to Expand Podcast, a DSD podcast about ortho insights. My name is Daniel Ramos, and today we have an interesting topic about aligners, predictability, and we are going to discuss the predictability pillars with someone I really admire, someone I understand that is one of the best orthodontists treating with aligners. I can say a friend because we already have some beers together and we have a lot in common, right? About where we came from in the South America, very close one to the other. I came from Porto Alegre in the south of Brazil. He came from Argentina, Córdoba, right? Martin Pedernera.
Absolutely right.
Welcome. Thank you so much. Today, we're not going to talk about barbecue and parrilla. We're going to talk about aligners, just for you to know, okay? And welcome here to Expand Podcast. It's a pleasure for us to have you here.
Thank you so much, Daniel, for the invitation. The pleasure and the honor is absolutely mine. I'm, just for the first minute that you mentioned something about this idea, this plan, you have my yes, because as you said, we are friends, first of all, and then we are colleagues. So really looking forward to it.
Thank you, my friend. Thank you so much. And well, I select this topic. It's a very vast and very big topic. And this is something actually us as orthodontists, I don't remember using the word predictability when I was practicing with brackets, with braces, right? Mostly because when a patient gets to my clinic and I start planning, I was imagining a lot of things in my mind and simulating in my mind, and already I could see in my mind again where I want to get in the end. But when we achieved this outcome, we couldn't compare because it was an idea, right? And we use some reference to move to class 1, to correct midlines. And most of the time, even mostly the patient, they couldn't get an idea. And the way I explained to my patient was, look, it's going to be good. It's going to be like this other case. We're going to move to this position. So the predictability is something new that aligners brought to us, right? And when we start reading about it, we have a lot of data already talking about predictability in aligners, and a lot of doctors, they use these papers to say, okay, but really 50%, 40%, we're going to talk more about these numbers soon, but it's not the same. I could do more, better with other system. It's not working. And I want to discuss with you this because this is something that I cannot agree because I'm seeing your cases. I can see my cases, I can see cases from the doctors who are working with DSD, and we are treating patients with aligners with great outcomes. So to say that is not working, we know that is not true, right? But my question for us to start, are aligners predictable?
For sure. When you were mentioning about that, and I do the same things, sometimes when I lecture, when I speak in front of people, friends, colleagues, and so on, that's one of the things that I mention. I don't remember going to a congress of fixed appliances, the technique or the brand that you want, lingual orthodontics, and I don't remember listening to that word, which is predictability. Is this predictable? Is this not? And one of the main things that I want to emphasize is the fact that there are two completely different techniques. From the perspective of one of them is fixed and is bonded into the mouth of a patient, which reduces a lot of that factor, which is the cooperation, the collaboration of a patient. And that's really important because what happened, I want you to remember, all of you, remember what happened when you have cases, brackets, and the patient comes to the office with 1, 2, 3 braces debonded. Is that working? I mean, is it really the arch wire producing the effect that we expected to obtain? No, that was the nightmare. We have to rebond the bracket. This is not working because the bracket is not bonded. It's the same. I mean, is fixed appliances predictable? It is, because if the majority of the time, if the 100% of the time, the braces are bonded onto the tooth, that's going to happen. Better or worse, depending on our capability of bonding the brackets in the perfect position, right? That was one of the factors of achieving a good result or not. We didn't rely so much on the cooperation of a patient. Nowadays, with the developing of this new technique, it's not so new, but compared to the fixed appliances, it is. There is another factor that affects the final outcomes, which is the collaboration of the patients. So aligners itself, they are predictable. They are predictable if the patients follow every single indication that we prescribe. Now, I can ask you, Daniel, how many of your patients you believe? Honestly, you can put your hands on fire, like we say in Spanish. I don't know if in English it's the same, but I can put my hands on fire that these patients, or all of my patients, are wearing the aligners this amount of time, 22 hours a day. I think in my patients, I wouldn't put my hands on fire.
Me neither.
Just because I'm scared, and you neither. So one of the factors will be the collaboration of the patients. We are working, and I love this kind of, can I say, not concept, but idea of, let's remember that we are imperfect human beings, imperfect doctors, working with an imperfect device, which are the aligners. And most important, we are working or placing our treatment into imperfect human beings. So why do we expect that to be perfect? Second thing. So probably we have to set our expectations a little bit lower. I'm not saying that we should expect worst outcomes with aligners than before, but we have to consider other things in order to increase predictability of the aligners. Now, going back to the question, I don't want to go around it.
But it's
Are aligners predictable? They are, and you can find in the scientific papers different, information, and you mentioned that you have data of predictability of this movement, that movement, and so on. Probably all that data is not matching. It's not, okay, one of the authors is saying that this movement is 80% predictable. And this other author is saying that it's 83.7 or 92. Which one should I believe? Well, you should hear to your own experience, because the patients of the author are not the patients of mine. The right time, how do we know in those papers if the patient completed the 22 hours per day? How do we know if the treatment plan was done exactly the same on my hands or in your hands? So there is plenty of, let's say, factors that affect to the predictability. But I can tell you in my experience that I can for sure tell you that aligners are predictable. We have to know, though, plenty of other things. What are the factors that affect to the predictability? And that's the way of tackling on those movements that we expect not to be as predictable as we would like.
Daniel Ramos here, just taking a quick break from this podcast interview to tell you about the DSD Aligners course. I host a live stream course where I teach dentists how to treat all the orthodontic cases with aligners, from simple to complex, with clinically validated and science-based protocols. The course takes place over 3 weeks and has 2 weekly sessions, plus several recorded material with very special guests. Whether you are establishing Invisalign or clear aligner provider, an orthodontist, or a general dentist just starting out, this course curriculum covers the common challenges with proven systems. To get an idea of what the course is about, you can access a taster class free of charge on the web page that is linked in the notes of this episode. Be sure to check it out, and I hope to see you at one of these upcoming courses. Now, back to the episode. You already mentioned what it is for me, one of the pillars for predictability, and this is a factor that we cannot control. I really like what you mentioned about we are not perfect, right? Everyone, us as doctors and the patient, we have our flaws and we cannot expect perfection. And collaboration is one factor, is one of the pillars. And how can we improve these? This is something that probably the artificial intelligence will never do. We need to create a connection with our patients. We need to be there, explain, motivate, and use technology in our favor and to make them understand and use more. And this way we can have better outcomes, because a liner inside the box is not going to move teeth, right?
Absolutely.
And then we have
yes,
all the factors that are more technical, more biomechanical, that every orthodontist should understand to make plastic work, if not the same way, because they are different, but with the same efficiency or similar to braces, which is a more familiar technique. I don't know, I don't imagine the periodontal ligament looking up with, I don't know, like the submarine, putting up a camera. What is making pressure here? Oh, this is plastic, so let's not move because plastic's not moving. I only move with braces. The periodontal ligament, he doesn't care, right?
Absolutely,
so if we put a pressure with our finger or for any device in the right spot with the right force to the direction we want, tooth will move, right? So what we need to understand is how to do this, how to use these biomechanics that we learned in the past with braces, how to adapt, right? And when I'm reading a paper that is saying that intrusion, we have around 30 to 40% of predictability, instead of understanding that it's not working, I'm understanding that I need to create a strategy, right? So for those who are listening to us, these studies, they are not implementing, for example, one that I consider, I would like you to comment how you are using it, or if you are using it, because you don't need to agree, right? They are not implementing, for example, overcorrection, which is something we always use with braces. When we need to intrude, we overband the arch wire so we can make force in the wire so we can fit inside the slot of the bracket in order to create enough force to make the movement we want. And this is something we can only do by bending wires in the software, changing the position. So overcorrection, Martin, do you consider there is something that can improve, can change these numbers? And how do you feel the companies are seeing what we were doing in the past with overcorrection to improve the artificial intelligence?
I do use overcorrection. Going back to the first part that you were mentioning, and we were talking about three main actors in this clear aligner therapy. One of them is us as orthodontists. How can we do things? How can we improve our practice, the work that we do every single day in order to deliver a better outcome? Well, studying, reading papers, getting to understand how they work, understanding that it's a different device that works with a whole different biomechanic So we can do things ourselves in order to be better orthodontics treating with clear aligners. So let's do not focus on, okay, I'll do the same with that I used to do with fixed appliances with the plastic, because they are different things, right? That's the first thing. Second thing, and it's very, close to what I was talking before, is the other actor are the aligners. So we have to know them. We have to know and really understand the way that they produce the movement. Okay? And then the third actor are the patients. So you mentioned something about connection, and I couldn't be more, I couldn't agree more with you with this. Still, artificial intelligence is not going to work in order to, to be friend of the patient, or to be, nice with the patients in order to obtain that collaboration. I do work a lot on my patients and on my relationship with my patients, because it's a win-win situation. I mean, they come to the office. I didn't bring them. I didn't, force them to come to the office for the treatment. So they need it. Of course, I need to work to live. And we all know that. Now, I need them the same as they need me. And I want to somehow create that bond together with them, trying not to work with, I don't want to punish them. Now, if you don't use the aligners, then I'll charge you for another additional aligner. That doesn't work. Not in my experience. I work on the other hand. It's like I try to give them prices. I try to, from the first moment when they come to the office, to let them know, look, this is going to be a trip that we are going to do together. Let's do it right. Let's do the best that we can. I promise I will do it. Now, promise me that you will do the best that you can. And I assure you that you will get something in exchange. I don't know. It could be, I heard many techniques, if you can say. Sometimes it's like, if you promise me that you're not going to be late, no one time, if I don't have to ask additional aligners because of your fault, then the last payment is on my side. I'll reduce the last payment. I'll give you an extra, bleaching. I'll give you the Vibera retainers for free if you promise me that you're not going to be late, that you're not going to cancel the appointments, and then that you're going to do the best that you can. We can read that. We can see that, So talking about that, creating a good relationship, bond with the patients, making sure that they are in your team, increases the predictability, for sure. Didn't mention gender and age, which are another things. Now, going back to the question, but gender and age, they have a lot of influence on predictability. And now that we are talking about that, in general, I discovered, I don't know you, Daniel, but in general, and this is a point for the women are, in general, I'm saying in general, like more organized, more, and at the end of the day, more collaborative than males in general. I'm saying, okay, we have everything, but
I agree. I have two looking to me right now, and I agree completely.
So you have to, but for sure, it's something that we have to consider, then adults versus kids, or adults versus growing patients. I can tell you that I could change without the risk of getting wrong, I could change almost all of my adult patients for growing patients. For many reasons. One of them, because children, growing patients, they don't lie. And if they do, you just get them like this. But another thing is biology. I mean, the age related to the biology, or the biology of the dental movement, it's huge. I mean, what are the papers saying? Okay, 80. You were mentioning, and I go to that part of the question about intrusion, overcorrection. Well, do you do it? Do you do it like systematically? It depends. Everything depends. Depends on, probably it wouldn't depend so much in gender, but it does. But depends on the age. Am I going to overcorrect an intrusion of anterior teeth in a patient that is, let's say, 16, 17? Am I going to do it in a male of 62? Well, my answer is going to be different if I'm talking of one or the other. Now, overcorrection, I've been doing or performing overcorrection when I was doing fixed appliances. I had some experience with lingual technique. And in lingual technique, as everything is indirect bonding, I used to overcorrect rotations, for example. And there was a really nice paper about Roth talking about, it was Roth and, it will come to my head, about talking about the amount of the loss of force of the arch wire while developing or while delivering the movement. So it's not the same, the amount of force that an arch wire can deliver at the beginning of a movement when the tooth is 45 degrees rotated. When it comes to the moment of there is only 2 degrees of rotation, what happened? It was really difficult to correct that. So I was incorporating the overcorrection on the bonding of the lingual technique, for example. So I am a user of overcorrection in clear aligner therapy.
And this is not new, right? This is not new.
It's not new. No, it's not new. And you were mentioning, for example, it doesn't matter what paper. You have to, at the end of the day, understand the percentage of predictability of your own cases. Okay, for sure. Information in the scientific papers are done, with a methodology in order to obtain some conclusions that are important and are relative to the cases that we have. But if we have a movement that is only 50% of predictable, let's say that if you plan an intrusion of 2 millimeters, what is saying that you cannot expect to finish the movement of only 1 millimeter. So over-engineering or over asking, for that movement, correcting that movement, at the end of the day, is going to take you closer to the final outcome that you have compared to the one that if you only correct in the clean check or in the digital treatment plan.
I really like the way you divided the topic, right? Because you kind of created like the triad between patient, material, and dentist, orthodontist, right? And all of them, they take a part in this process, and it's not possible to have a good outcome without a good orthodontist or without a patient collaborating or without a good technique, biomechanics, planning software. So this needs to be combined, right? When we talk about orthodontics and software, to learn how to use this new tool, understand that we are doing differently things that we used to do before, right? I want to move to a very tricky question, actually, and I'm going to make actually the same question 2 times, change a little bit. So I would love to hear your opinion. The first one is, can we treat all cases, all malocclusions with aligners? And the second one is, can we treat all cases, all malocclusions only with aligners? Do you feel the difference here?
Nice 2 questions. It's really, I feel the difference, and it's really important. So first one is, can we treat all malocclusions with aligners? I would say it's 100% yes. And it's not only me that I say this. You go to congresses in the last 5 years, and every year I'm more amazed of the things that you can achieve we can achieve with aligners, surgical cases, impacted teeth management, combined with maxillary expansion, combined with or in growing patients. It's amazing the things that you can do with with growing patients. Kids, even kids, first phases treatment, deep bite, open bite, any single malocclusion, I could, no discussion, say that you can treat it with aligners. Now, second question I understood is, can you treat them only with aligners? That's 100% no. 100% no. And whoever says that treats, I don't know, every malocclusion that I mentioned or every clinical situation that I mentioned just a minute ago with aligners, I'll find it hard to believe. Okay? Why I say this? Because I'm not only convinced, but I believe that the technique it's very powerful, very powerful. It's the predictability would be huge in some movements. It will be reduced in some other movements, and we were mentioning that. Let's just for mentioning something, rotation of canines. That's one of the challenging movements. Extrusion. It's one of the movements that only with aligners, it's not that it's not doable, but the predictability is really low. Now, in order to be able to treat all the things that I was mentioning before, surgical cases, impacted canine, for sure, I not only believe that I can encourage people to consider using a hybrid approach. It could be TATs, could be skeletal anchorage, it could be sectional wires, it could be whatever. And this is something that I mentioned. Look, Daniel, communication with the patients is so important, and we were mentioning, how to, make them a part of your team and so on. They have to know that we are working with a technique that alone it's not capable of doing everything, especially in those cases, impacted surgical cases, impacted canines, surgical, when there is a skeletal transversal discrepancy. So in those cases, extractions, okay, something that is more day by day, extraction cases. In those cases, I make sure that my communication with the patients is clear. I'm working only with aligners, the part that I can only work with aligners. But if I need a helping hand, in order to achieve the best outcome for you, because it's for you, then I'll do it. So I make sure before I start an extraction case, an impacted canine case, those cases that I hardly believe that I probably will need something extra, I just mention that. I tell them, look, the treatment will include everything we need. So if in one moment I believe that I need power arms and elastics, if I need buttons and elastic, because buttons and elastic is an auxiliary. So if someone tells you, no, I do every single case only with aligners, well, are not using buttons and elastics for class 2, class 3, then probably you're not treating every single malocclusion. Now, going back to the explanation, I make sure that my patient understands that if I need to use power arms and elastic chain, if I need to use sectional wires for 2, 3, 4 months, I'll use them. If I need to use TADs, I'll use them. If I need to use a skeletal expander, like now MARPI, or I'll use it. Okay? So they have to know that those auxiliaries are there for what the word says, for auxiliary. It's to help. Okay, so, and it's very related, just to finish with this part of the topic, it's related to the predictability. So when you mentioned at the beginning, it's very vast, for sure. And the fact that one movement and other movement, they have certain, reduced predictability, we have to know that somehow it's in our hands to use something extra, something to help us in order to make it predictable. Actually, when I lecture university or private courses or whatever, and I'm talking about tats, I make sure that everybody understand that tats for me are not made to work, or to make teeth fast. It's to make predictability higher. It's to make what I want to happen to finally happen. So for sure, it would be two questions. First, are we capable? Are we, able to do whatever malocclusion or to treat whatever malocclusion? It's absolutely yes, with aligners. Only with aligners. Don't believe it.
The fun thing here, the interesting thing, Martin, is if I change this question to braces, is it possible to treat all cases with braces and only with braces? Still, your answer will be yes for the first and no for the second.
Yeah.
And we know this for ever, right? Since we started as orthodontists, that braces also need help. And we started doing much more cases, complex cases, adding TADs, adding expanders, combining, going hybrid with braces. And one of the biggest mistakes for those who are using aligners to believe in the software, as it was the only one truth. Because the software, you can simulate everything. The software, you can expand 10 millimeters if you want, only with aligners. But it's our job to understand that it's not going to happen because we have limitations, bone limitations, and the plastic can expand. Again, the root doesn't know what is making the pressure, but the same limitations we had for braces, we also have for aligners. And understanding that aligners are a great tool, amazing, since this is why you, me, and many, many other great orthodontists started using, implementing, and it's good for the patient. So I believe we are both in love with the system, but understanding the limitations and understanding when we need to ask a little help from our friends, the adjunct therapists, right? And this topic, the hybrid, I would like to, you have a clinic that you practice orthodontics, seeing a lot of patients, right? And probably maybe you don't have the exact number, but I can say here in DSD that we help several clinics all over the world. Almost more than 90% of the cases we are going hybrid. Very few cases we can treat the orthodontic part at least only with aligners. Usually we are using some elastic. We are recommending some adjunct therapies such as a vibration device or TADs, sometimes an expander, MARPI, SARPI, DOM, orthognatics. Why? Because we have the limitations of what orthodontists can do alone. Most of the time, we need more than this. In your experience, in your clinic, what are the situations that for you, okay, here I go hybrid? What kind of movement? And I don't know if you can give us an idea also in terms of proportion, how many cases, okay, this case I can do only with aligners, that's simple, this other, no way.
Yes. You mentioned like 90%, probably if I consider, let's do not consider buttons and elastics, okay? Because it's something that it has to be used, but power arms, sectional wires, buttons and elastics for vertical engagement, intercuspation at the end, tats, probably I'm very close to that 90%. Absolutely. Now, when do I consider that? There is kind of, and I like one thing that one of my friends, Alessandro Greco, from Italy, he classifies the patients or the cases, not the patients, but the cases in, let's say, A, B, and C. Like A, no need for auxiliary. B, like it can be done without auxiliary, but the use of the auxiliary can decrease time of treatment, can decrease the number of aligners, for example. And then C, when it's mandatory. Okay, surgical cases, impacted canines, extractions, and so on. Now, I use that kind of classification, but based on the information that we have on the literature, okay? So I just make sure that I understand what are the movements that I have to perform in a certain patient. Let's say that you come to my office, Daniel, for an orthodontic treatment, and you have class 2 and deep bite. So I know that somehow I have to correct the sagittal movement. I need to know the amount of class 2. I know that if we want to correct the deep bite, also I need to know if I have to make intrusion in the anterior teeth, upper or lower or both, if I have to or not to do posterior extrusion and so on. So the fact that I know every single movement that I have to plan on that video game, which is the clean check, let's say, first of all, I need to diagnose. I need to be sure. It's like, facing or organizing a trip. Okay, I have to go to Barcelona. Well, first of all, I need to know where I am. The GPS can't calculate the trip if the GPS doesn't know where you are. No? So I always insist, for example, to the master degrees students when I go and lecture them, they have that tendency, and we all did, that tendency of, okay, the patient comes, need to see the clean check and see if this attachment is correct, if the movement seems predictable or not. Wait, did you comprehensively study your patient? Did you deeply try to understand what the initial situation looks like, how far away is from normal? Because that will let you know the amount or the range of movement that you have to do for every movement. For example, let's go back to you, distalizing. Okay, if I have to distalize only 2 millimeters, if I read every single paper in the literature, for sure it will tell me that more or less that's something achievable only with aligners. And you mentioned before, with a good planning, good planification, and let's do not forget about the patient. Because if, Daniel, you're not using the aligners, only, I use it only 4 hours a day because I'm very busy, man. Well, even if it's 1 millimeter, probably that's not going to happen. So let's do not forget about that. Now, when even one single movement of the one that you need, distalization, intrusion, or your deep bite, or even extrusion, exceeds what is, the range of predictability, and we get into, to that dark side of the aligners, which is the moment when the distalization is not so predictable. Then that's the moment when I say, it's not because of me, it's not because of you, it's because of, it is because of you, dear patient, because you don't only have a class 2 of only 1 millimeter or 2. You have a class 2 of 5 or 6. So I have to consider working with something which I don't like to call extra, because it's something that is needed because of the biomechanics.
Yeah, I like your example about the trip, right? Because depending where you are and depending where you are going by plane, by boat, by car, by bike, walking. And sometimes traveling by plane not always is the best way. To go to Barcelona, I prefer much more from Madrid to go by train, right?
Absolutely.
I save
it's more
time.
efficient for you. You can work.
So, but imagine that I only have I don't have a plane, but imagine that I have a plane. I cannot go everywhere. And to think about aligners is like to want to travel worldwide only with one method of transportation, and this is not the best most of the time, right? So probably we need to combine, right? Because the train will take me to the train station, but from the train station to the hotel, maybe I need an Uber or a metro, right? So, and this is us planning the case, understanding where we are, diagnosis and planning, motivating the patient, making the patient understand and collaborate, right? Another pillar. Creating the best transport to get there, understanding what are the tools we have available to make this trip the fastest, the most predictable, most comfortable possible, right? And then offering this to the patient. Ideally, we should always offer, because I can see a lot of doctors to offer tests just because of these, like it was an awful thing to use, and you know that is not a big deal. It's simple, fast to insert, even faster to remove. As soon as the patient gets adapted, it's something easy to live with it. And in the end, it's going to make the anchorage and the predictability of the movements much better, right? So not avoid, how can I say, not think by the patient, right? As the patient, put the patient as, I don't want this. Let the patient make this decision, right? It's our job to offer the solutions. I believe you agree with me, and we need to offer everything we can do. So even for the cases classified in the B, okay, I can do with aligners. This is because the ones that they are in C for you, it's clear. You're going to say, man, if you are not going to do like this, maybe you should look for another orthodontist because I'm not going to treat.
Absolutely.
Right? The A also sometimes is clear. The simple case is aligning, leveling. I don't need it. The B is the issue for a lot of orthodontists. They get lost there because they believe sometimes what the companies are saying, and I can do only with aligners, and then they start losing tracking, the treatment extend to more time just because they didn't mention one adjunct therapy that can be used to help. And this is bad because in the end, if the patient get to know this from other orthodontists, he's going to ask you, Martin, why you never offer me this? What are you going to answer to this patient? Oh, because I thought you wouldn't like it, but this is my decision, right? So we cannot think for our patient. We need to be very scientific at this moment. We need to understand, look to the literature, see if it makes sense to research, to test, to use it. Okay, if it's good, works, and there is evidence, so I need to offer it. If it's expensive, if my patient, he doesn't want, okay, it's your decision, right? And this mistake I can see many of our colleagues doing when we talk about, for example, the use of vibration device or photobiomodulation or TADS or MARPI and orthognatics, right? How many times, maybe even I did in the past, I'm not going to talk about orthognatics. I think it's too much for this patient. Without a proper diagnosis, if this patient has airway issue, probably this is the solution for this patient that actually is going to give him more quality of life. And to try to solve without, it's not going to happen. And then we're going to say it's not predictable.
Yeah.
It's not that it's not predictable. It's that it's not the best plan, right? And the best diagnosis. So,
yes,
I think we could get to very interesting conclusions here, right? In terms of predictability. We could expand here more hours and hours talking about biomechanics, strategies, staging, protocols for overcorrection. But this is very visual, and this is more for a lecture with slides, right? But what I think you could get to the point that I was hoping and I really wanted, that it's a combination of factors, and this triad, these pillars, we cannot do this alone. We depend on a patient, we depend on a good system, right? But the basis will always be diagnose, planning, and this connection with the patient, right? Because in the end, this is what is going to make the treatment to work or not. For us to pack everything, and for those who are listening to us, to leave with a final message, Martin, about predictability and aligners. Consider everything we discussed. If you need to put this in a final message, what would be for you the main factors for them to consider, right? The final tip in this topic so they can finish this podcast today happy and put in practice tomorrow in their clinics?
Yes, I'll go back to that, to those three main pillars. Those three main pillars that we mentioned. Let's say that again: patient, aligners. When I say aligners, is the whole technique, the brand, the manufacturer, the quality of the system, and us as an orthodontist, we can influence and go back to that classification. Every single B patient, the one that probably need auxiliary or probably doesn't, it can move from B to A because of cooperation. It can move from B to A because of a good planification of us. And it can move from B to A because of a good quality of the system. Now, if any of the three pillars, like if the patient fails, wearing the aligners, the amount of time that they need, following every indication that we give, it can easily go from B to C, for an extreme necessity of something auxiliary. And if we plan our treatments, if we receive the treatment plan, accept that easily, probably going to need, depending on the malocclusion, obviously, to a C classification. And also, if we don't work with something with quality, with quality control and so on, for sure, the amount of cases that we really need something extra will be higher than compared to a good system. So I like to probably end up with go back to dictionary and look for predictability, and it's synonymous to efficacy. Efficacy means that the possibilities or the fact that something that we expect to happen, that is going to happen. And I hardly believe that it's possible. And it's possible for us. We have good techniques. We are good doctors. We need to keep learning, keep reading in order to be, to everything can be possible. For sure, working together with the patients will make it happen.
It's amazing, my friend. Well, I believe it was a great message. Thank you so much for discussing this topic. I am really passionate about this topic. I really like doing quality controls. This is something that improved a lot the quality of my treatments, to be able to evaluate what I'm doing. And aligners, we can do this with aligners, right? Because we have a final destination very clear, and we can compare using the digital later. And this way we are getting better. And more, I believe that more doctors, they're going to start using aligners as the main tool in their clinics, if this is not a reality in most countries right now, right? I really hope everyone at home enjoyed listening to us, to the Expand podcast, with my dear colleague and friend, Martin Pedernera, from Argentina originally, now living in Spain, very close to me here in Madrid. So, my friend, thank you again. And for everyone, see you in the next episode. Bye-bye. Thank you for listening to episode 5 of Expand with my guest, Dr. Martin Pedernera. If you found this interview as interesting as I did, be sure to like and share it with your professional network. In the next episode, I talk to TPS provider Matthias Pieper. Subscribe to Expand not to miss it.